Good afternoon, everyone. We're really excited to talk to you today about the Vascular Ring and Compression Program here at Boston Children's Hospital. My name is Jen Piselli. I'm one of the physician assistants here in cardiac surgery and one of the co-coordinators of the Vascular Ring and Compression Program. And we're really excited. We have a really great panel today to talk through the program. So I think we get started by just doing some introductions. Dr. Baird, if you wanted to get started with that. Great.
Yes. Christopher Baird. I'm one of the cardiac surgeons here at Boston Children's Hospital with interest in patients that have vascular rings and vascular compression syndromes that affect the airway and esophagus. And this is a program that we really became interested in as a somewhat of a joint program a number of years ago, bringing together the specialties of general surgery and cardiac surgery to really combine our expertise to tackle some of these difficult problems. Dr. Zendejas, one of my partners in this effort from general surgery, is here as well on the panel. Ben?
Yes, hi everyone, nice to meet you all. And we're very excited to share with you our approach to these challenging situations. And as Dr. Baird was saying, I think what you will take out from this discussion is that the benefit and the added value that a team approach to these situations come when we're faced with these challenging situations. I think we both and all of the members of the team bring different aspects to the improved care of patients who are often faced with disjointed care elsewhere. And so I think that's what we try to add to the situation.
Great. And then Naomi, do you want to introduce yourself?
So hi, I'm Naomi. I'm one of the surgical physician assistants from the cardiac surgery side. And this was kind of a new program to me. I primarily work in the ORs, but this was a new and exciting opportunity that I was given. And I'm very happy to work with this patient population.
Okay, and Leanne, you want to wrap up the intros?
Sure. I'm Leanne Cole. I'm a pediatric nurse practitioner within the general surgery department. And I came from one of the cardiac surgery floors. And so I have a background in cardiac surgery and have taken care of vascular ring patients for, over 5 years now. And then I transitioned into this role, which allows me to kind of further care for them and see them both inpatient and outpatient. So it's been a great change.
Great. And so Dr. Baird and Dr. Zendejas already gave us a bit of an overview of what the program's goals are and what we hope to get out of it. Leanne, if you don't mind just touching in on a little bit more about who exactly is a part of the team.
Yeah, so you've kind of met the core members of our team, which is, our cardiac surgeon, Dr. Baird, our general surgeon, Dr. Zendejas, and then, Jen, Naomi, and I are the three advanced practice providers on the team. But we also have colleagues in gastroenterology, pulmonology, feeding team specialist, nutrition, ENT. So the team is really multidisciplinary, and we take that sort of approach when caring for these patients because we know that they have pretty complex issues that require a lot of services to kind of address all of them.
Great. I think that really covered everyone who's involved most of the time with our review of these patients. And Naomi, do you want to just touch on kind of how we get referrals and then what we do with those referrals to review the cases here?
Yeah, great. Thank you, Jen. I'm going to start with how we get referrals. So first is we can do, you can get through us to the online second opinion portal. Secondly, you can contact us directly, either through our clinical coordinator, who's Paulina, by email or phone. And then you can also contact the advanced practice providers, either Leanne, Jen, or myself, or the surgeons directly. One other opportunity is that your home cardiologist can also reach out to us directly. Then kind of going through how we present, how your case is reviewed by our team. Once you've made the second opinion request, our administrator, Paulina, or on the general surgery side, either Dory or Michelle will reach out to you and start compiling records. Some of the things that we might ask for are things such as echo reports, CTs reports, bronchoscopies. Once we compile the medical record, either Jen, Leanne, or myself will go through the record, and then we're going to reach out to you. So some of the questions that we're going to ask you are going to be to obtain exactly what respiratory and GI symptoms that your child is experiencing. From there, we will go ahead and we're going to review all the studies at our multidisciplinary conference. Again, this conference is very comprehensive in that we have both cardiac surgery, general surgery, ENT, gastroenterology, and pulmonary there. At this time, we're going to review your CT scan. We'll review if you have an esophagram or things such as a bronchoscopy. We'll review that during conference. During this conference, then we'll make a plan for your child. Things that we will include are if you need surgery or not, we'll review that with you. And then any preoperative tests that we might include, such as an esophagram if you previously don't have one, or something like a vocal cord check.
Great, that really took us from intake and then all the way through our team's referral. And so now we're at the question where if a patient is referred for surgery, then what will their care look like while they're here inpatient? And I think Leanne, would you be willing to talk about that and just elaborate more about what that looks like?
Sure. So from the time the patient gets here, there is going to be a lot going on as far as getting that patient ready to go into the OR. And then the surgery itself might only take a few hours, but they're between anesthesia, prepping that patient and getting them ready for sedation, to recovering the patient, and to bring them all the way up to the ICU. That might not happen until mid-afternoon. And then once they get to the ICU, they may have their breathing tube out, or the breathing tube may remain in. It's really going to be whatever's best for the patient, and anesthesia is a big part of making that decision. Once the breathing tube is out, the ICU will kind of determine when the patient is appropriate to go to the floor. And that's usually about 1 to 2 days after the surgery. And then once they're on the floor's job is to make sure that they're ready to go home. So they'll be working on getting any additional chest tubes out, making sure they're eating and drinking enough. Not perfectly, but getting back to their baseline, having adequate pain control, just with Tylenol and ibuprofen. By the time they go home, they're able to kind of up and walk around if they do walk. So all those things, kind of getting them discharge ready, and then ensuring they have appropriate testing before going home. So we usually like to do an echo prior to discharge. We like to check the vocal cords one more time just to make sure that they're both still moving appropriately. And then any additional chest x-rays or lab testing that they may need, just to make sure all of that is in good condition before discharge.
Great, thank you for going over all of that. And so now, Leanne, again, can you touch on our follow-up plan going from that acute phase and then the more long-term follow-up that we offer?
Yeah. So we really are in this with you guys for the long run. And in that, we're going to want to follow up closely once you're discharged. And that's usually done at first with a 7 to 10 day follow-up appointment, which is most of the time just kind of a check-in to look at the incision, make sure there's no big issues since you've gone home. And then you'll have a follow-up appointment, usually with me at about the 1 month post-operative mark. And that is done virtually. All these appointments are mostly done virtually. And at that appointment, we'll talk about your symptoms since surgery and any issues the patient may have been having. And if everything has gone really well up until that point, we probably won't see you again for 6 months unless issues come up. And then we'll see you guys at the 6 month mark. And that appointment is most likely going to be with Jen and Naomi, and then again at the year mark. And so that frequent follow-up is purposeful so that we can really check in and make sure, the patient is doing well and that there's no symptoms, we really need to start thinking about more, and no additional testing is needed. We're always available by email or by phone or through the My Children's portal. So again, we'll continue to be kind of there for you and your children as needed throughout this process, both before and after surgery.
Great, thanks, Leanne. We'll give you a little break now, but I think with all of that, we've basically gone from intake and referral all the way through the hospital stay. So now I think it'd be great to do some more surgically focused discussion. If Dr. Baird and Dr. Zendejas wanted to start talking about the different diagnoses we see and the typical surgeries that we see done for these patients.
Ben, do you want to start or?
Yeah, so I think the first thing is to try to understand the problem or figure out the anatomy. I think the first sort of step is in the review of the imaging is defining the anatomy. Oftentimes the diagnosis is a little unclear, and so reviewing the anatomy helps us try to identify exactly the type of either ring. Is it a complete ring? Is it a partial ring? Are there associated either intracardiac or extracardiac issues that need to be addressed concurrently? So define the anatomy, and then also try to put together the anatomy with the symptoms. I think many times if we focus just purely on anatomy and not on the symptoms, I think is where we may not see the full picture. Some patients may have a very abnormal anatomy or concerned anatomy, but their symptoms are non-existent, and so that plays a lot into the decision making as to what to do. And so the symptoms sort of drive the testing or the necessity for surgery. So we'll definitely try to get as much information in terms of what the patient's actually experiencing from that regard. And then the other main thing to keep in mind is that sometimes it's not just a vascular ring. And so we touched about a little bit on that. We really want to make sure we leave no stone sort of unturned so they can really not miss anything. You know, we look into children with vascular rings or vascular compression can often have other issues related to aspiration, esophageal issues, intracardiac issues, feeding issues, aspiration, reflux, etc. So we want to make sure we're capturing the whole gamma of items so that we do a holistic evaluation.
I think when we start to think about that and then do the evaluation, then we can start talking about the different anomalies. And I think they're common ones that folks often think of when they think of a vascular ring, and it can be double aortic arches or a right aortic arch with an aberrant left and a large diverticulum of Commerell, or it can be a left aortic arch with aberrant right subclavian, which technically isn't a vascular ring, but we often think of it, or a lot of people think of it as a vascular ring because they often present with similar symptoms. The so-called circumflex aorta, pulmonary artery sling. There's a whole bunch of different anatomic lesions that can cause similar states. And that's why the testing is so important in the imaging that we go through with our imaging colleagues to get the right studies to identify the exact problem. Because really, not only do we have to identify the symptoms, then we identify the anatomic problem, then we have to decide on the surgery. And that's where Dr. Zendejas and I can go back and forth on our different expertise and different approaches to really provide the most optimal access to get at this problem. You know, for example, if it's a typical right aortic arch with a large diverticulum and an aberrant left subclavian artery, the typical approach is through the side or the back. And we would go in through the side or the back and deal with the lesion and make sure to address all the components of that. And we'll talk a little bit about that in a minute, I think, in terms of what's involved in each surgery. But so I think the approach is important. It depends on the type of lesion. Now, I think as one starts to think about the different types of surgery, it's not just divide a vascular ring. And when we go into the operation, there's a number of important points. And maybe Dr. Zendejas, if you want to touch on some of those, of some of the intraoperative details that are important to us as we work our way through the operation to make sure we don't miss things or don't damage other parts of the body.
No, that's totally true. I think the biggest thing that we want to address is that how do things look before we divide the vascular ring and how do they look after in terms of particularly the airway, if we want to touch on that. The degree of compression on the airway, we need to assess that preoperatively with the bronchoscopy typically to try to see what percentage of the airway is compressed, both from a static component, meaning with normal breathing, and how much is it with a dynamic component, meaning when the child is coughing and actively breathing, because that can be a totally different appearance. And generally speaking, the thought process has always been that once you mobilize or divide the ring or move the blood vessels, that the airway compression should get better on its own. It doesn't always do that. And I think that's one of the biggest lessons that we've learned, that if you think about it, that airway's been compressed for sometimes years, or it was developed in that position. And so it doesn't always prop open as you would imagine it would. And so in addition, the dynamic component also doesn't necessarily get better if you don't address that, meaning that how the trachea moves with active coughing and moving around. So being able to understand that, and at the same time, intraoperatively look with the camera, once we've divided the ring or removed the compression, to address is it's still present, and then to address it with a series of sutures such as tracheopexy, or additional maneuvers such as a splint, or even sometimes a tracheal resection if it's a segment that needs to be removed entirely. So that's one component of things that we look at intraoperatively.
I think the other, Ben, maybe it's worth touching on, is monitoring the nerves. That's a common question we get in terms of the current.
That's a great point. The nerves that control the vocal cords are intimately related to the trachea and esophagus and the heart and the blood vessels. And so those really finicky, small cord-like structures that are in the operative field. And historically, we have always sort of cared for them and obviously not tried to divide them or hurt them. But sometimes in the reoperative setting, when a really tiny situation, if we're not actively thinking about it, they're very high risk for injury. And the injury presents as often issues with aspiration or difficulty breathing as well. It's not so much the voice changes, though that could also be a factor. So that's why we want to, before the operation, we check the vocal cord function with the little camera down the nose, and also after the operation. But more importantly, in addition to just being careful to try to protect them, we've also doing something pretty novel, which is called intraoperative recurrent laryngeal nerve monitoring, which means we put a little special sensor or sticker around the breathing tube that goes inside the airway of the child, and that is connected to a system that gives us a signal each time we get too close to the nerve, or we're trying to figure out is that structure of the nerve itself. It gives us some feedback as to whether the nerve is functioning or not once we do the operation. So in doing that, we've been able to decrease our nerve injury rate significantly. We're looking into the actual numbers and the data, and hopefully we'll be able to share that with you all shortly. But that's been a significant change in how we've approached not just vascular ring surgery, but cardiac and esophageal surgery that put the nerves at risk. So
I think that leads into another question that we commonly get is, and that's, do we perform reoperations? And I think this is it's always an interesting question. We'll get calls or referrals from families and say, well, we still have the symptoms. Would you have done it the same way, or would you do it differently? And what would you do now? And our goal isn't really to second guess what's been done, but how do we address the issues now? And so it goes back to a lot of what we've been talking about. We like to get the cases when it's not in a reoperative setting the first time around. And we take all of these precautions that have just been described so we don't have the reoperations. But nonetheless, when we do a similar workup with similar studies to try to understand exactly the problem. And then some of these type of operations require even different approaches. Some of them may require bypass. Some of them may require an entry instead of from the side, from the front. Maybe it requires us moving a blood vessel in a different way. So it requires a little bit of outside the box thinking, if you will, to try to come up with solutions for some of these more complicated and even rare problems that maybe weren't recognized or weren't completely addressed at the first time around. And so I think that leads into a little bit of the imaging. And one of the newer modalities we've been using is when we get a CT scan, our engineering team now can take those CT scans and do three-dimensional modeling and simulations and really give us a much better grasp of the structures and how we need to move them and where we need to move them. I think another piece of that maybe that worth commenting on, Ben, is how we use the CT scan to evaluate the blood vessels of the spinal cord, and why sometimes we ask for a new CT, for example, if we get a CT from the outside.
Yeah, so it's very important to have accurate information and updated imaging. And so sometimes we may review the scan, and if the phasing of the contrast wasn't perfect, or we can't see exactly what we need, we may ask you or your patient to get a repeat scan, partly to get a good view of things, but also to probably look at things that may have not been thought of initially. And so sometimes when we have to move or divide blood vessels and reimplant them elsewhere, we want to make sure that the blood supply to the spinal cord is intact, and that we don't have any issues with that. And so it's important to know where it is, although the vast majority of the time it's in an area where it's not at risk, but in that 1 to 2% of the chance that it could be, it makes a big difference. And so we want to be prepared so that we don't lose any specificity in the time of the operation in terms of how to be able to manage this.
So I think just to summarize kind of all of that is we really like to take a comprehensive approach, multidisciplinary approach, looking at a number of aspects to really bring together the best options and best coordinated care for your children.
Thank you both for that discussion. And we actually had a question come in, and it aligns with something that comes up a lot with our families, which is what makes the surgical approach here different at Boston Children's than at other hospitals? Dr. Baird and Dr. Zendejas, could you speak to that?
Yeah, so I think we've touched on a fair bit of that. I think probably most importantly are some of the details. And it's nice to have folks from different departments with different interests and different specialties to think about different pieces of the care. You know, we may be presenting a case at conference, and one of the advanced practitioners may say, well, what do you think about this? We didn't talk about the feeding aspect in this way. Do we need to get speech or so-and-so involved? And it really holds each of us accountable for really providing the best care. So I think that is one thing that's very important. A second thing that we haven't really touched on a lot is the perioperative care. The operation is one thing, and let's say we can do a perfect operation, but the nurses and the care that's coordinated around those patients being taken care of in the ICU, and how the breathing tubes are managed when they're coming out. How do we take care of those patients to get them feeding again? Who takes care of the patients on the ward? There's a tremendous effort that Boston Children's in general puts into taking care of these patients. I personally think that's a really tremendous advantage by coming to a place like Boston Children's. So that's in addition to all the other pieces of care that we've talked about. And I think maybe Jen or Naomi, you were going to talk a little bit about some of the innovations and new things that we're talking about and doing that really you reap the benefit of, if you will, by coming here. And maybe you want to talk about a few of those?
Yeah, Naomi, if you want to touch on those. Dr. Baird already kind of started the discussion of 3D modeling, but I know there's a couple other topics we have.
Yeah, I think the 3D modeling, especially working with our engineering group, has just been spectacular, especially I think in the cases of the reoperations like Dr. Baird already touched on. But I think even for some of our more typical vascular rings, I think it still brings a whole nother aspect to being able to look at those 3D modelings in conjunction with all of your other testing that makes a big difference. Some of the other things we're also looking at is more standardizing both our respiratory and GI questions so that we really do have like your baseline when you come to us. We can talk to you post-operatively and then kind of keep tracking you down the line. And then we have an actual way to quantify how your symptoms are getting better so that we can better educate other families too as to what to expect. And I think that's going to be a really great innovation for us.
Great, thank you, Naomi. So we just have about 5 minutes left. And so I want to give everyone a chance to kind of give their last overview of what they want to say to the audience today. But before we do that, we just have one question left to address. And I think this is one that'd be good for Dr. Baird or Dr. Zendejas. It's, what is your average case volume for vascular rings? And that's within a year, for example.
Yeah, so just in general, just to give you an idea, our numbers have steadily been going up over the last 5 to 8 years, I guess, just in terms of these types of patients. In general, now, Dr. Zendejas and I are scheduling joint cases, 1 to 2 cases a week. And we generally are doing that on every Tuesdays now, and then add another day or half a day if we have to. So, you know, if you add those numbers up, you can kind of get a sense on the total numbers of cases that we're doing. I think you know, probably in the 75 to 100 range over a year, if you will. It a little bit depends on the type of case you're talking about. And we often don't just look at a vascular ring case. We'll think about a vascular compression case or even some other complex airway cases. And if you group all those together, there's probably even more than that. I don't know, Ben, do you have any other comments on that?
No, I agree. I mean, I think combined, Dr. Baird and I work at least 1 or 2 days a week, but even on the other days of the week, we also have some overlap, and particularly my side of things, we're also always working with the esophagus and the airway, Dr. Baird, also, so that the added volume and expertise isn't just based on that particular entity. And I think that's what also brings value to our team, is that on our other days, so to speak, or in our other times, we're also taking care of very challenging kids with similar problems to some degree. And so we bring that into this group as well. So we bring that experience with the esophageal and airway expertise that we've accumulated here as one of the higher volume centers in the world for esophageal and airway problems. And then Dr. Baird with this expertise with neonatal cardiovascular surgery. It just adds to the whole value.
Great. And so then now we just have a couple minutes. So before we close out, can we just go around and have everyone give their final thoughts? We can, I guess, start with Dr. Zendejas. You're on screen already.
Well, thanks, Jen. Yes, I think it's obviously a short time to kind of go over everything in detail. And we'd love to be able to spend more time with you to kind of refine your questions and get to the bottom of a lot of these issues. And a lot of these, we may not know the answers right away, but we're actively studying them to try to find out the best way to care for kids with vascular ring and compression syndromes. And so I think we're definitely interested to making things better for you and your family members. So help us help you, and nice to meet you.
And Dr. Baird?
Yeah, I would just like to conclude by saying thank you for joining and reaching out. And we're happy to review and give our opinions on your children, whether it be the first time around, or if the decision is to come here the second time around. If you need a reoperation, we make no judgment, and we're happy to review and support that. So along the process, I'm proud of the team and everyone's contributions, and I think it really has made tremendous advancements in the care of your patients.
Great. And Leanne?
Yeah, I mean, I definitely agree that, having a team that's completely dedicated to these sorts of complex issues, and, that is from so many different specialties that have come together to kind of care for your children and give our opinions about what the best treatment options are, and then kind of follow them throughout the course of their operation, hospitalization, and post-op period is something very unique. And I don't, think a lot of different centers have, no other center has it, I don't think, for a program such as this one. So, again, I think it's pretty special. And just to build on what everyone else is saying, we'd love to talk to you more about your children and review their symptoms and kind of see how we can help.
Great. And Naomi, you want to wrap us up?
Yeah, again, thank you, everybody. I just want to say is between Jen, Leanne, and myself, we're going to be there for you every step of the way. We'll talk to you on the phone. We'll meet you in pre-op. Some of us may join you in the OR, and then we'll see you up on the ICU and in the floors. And then you'll always have us when you go home to be able to, if you have concerns, you'll have a friendly face to reach out to. But thank you all again.
Yeah, so thanks everyone for your time today, and everyone here for sharing your expertise. I think we covered a lot of important topics, and as we touched on, there's still a lot to go through, but we will definitely see you next time. And then for this webinar, this was recorded today, so if you wanted to rewatch and just re-listen to the answers you heard, that'll be available probably within the next week or so. And the team that coordinated this will be emailing all the folks who attended, and so you'll be able to get contact information through there. I know there was one Q&A left requesting contact information, so that's how you can reach out. But thank you again, everyone. Have a good night.